So let's start, if we may. Please be seated, be quiet. Let's start with this second roundtable. This table was programmed, was planified for tomorrow, but as two of the panelists have a different event, another exchange in Nice, in southern France, they will have to rush out at 2 o'clock sharp. And so I apologize if we have to quit the debate afterwards. Let's try. I hope they will be able to answer all your questions, but please let's keep it in schedule so that they don't miss the plane. So I'm going to introduce you. You all have the names of the panelists in your folders, and so if you want to know them more in depth, you have some presentations and with some publication that the own panelists selected. This table is about prevention and protection policies in Europe. Now we're talking about public policies and preventing and protection programs. The legal aspects will be addressed afterwards in the next table. We have here four marvelous panelists. We thank them for their participation in this Congress. One of them is
del programa académico
multisectorial. A partner of the multisectoral program in order to avoid FGM is our friend Elise Leye. She is representing the Vrij Universiteit of Brussels. She will talk about FGM prevalence and its estimating prevalence of FGM in Europe. I think she will be able to share with us all the work done in the academic and demographic field on estimating prevalence. Then Elise Johansen will take the floor. She works in the Norwegian Center for Violence and Traumatic Stress Studies. Is it post-traumatic or traumatic? Traumatic, I'm sorry. And she will talk about conflicts between rules, legislation in Norway. More specifically, she will talk about prevention and protection policies in the silence code and ethnic stigmatization. Then Sarah Johnsdotter from Malmö University will speak. She comes from Sweden. And, well, the title is the Candy Legal Concept of Neglecting of neglecting of care. How can I translate that in Spanish? As a prevention tool in Europe. Potential and risks of a new approach in the lines of protections phase versus FGM. Well, she doesn't talk about mutilation. She talks about cutting. Last but not least, Hazel Barret will take the floor. She comes from the University of Coventry. Hazel works in the Replace European project. It's a very innovative project, and she will talk about it. This project ended, if I'm not mistaken, a year or two ago, am I right? But it will be relaunched as a second series, and it has a lot of lessons learned that she will share with us. She will talk about working with African communities in Europe in order to stop FGM the replace method. And please, Elise, delight us with your speech.
Thank you, Magaly, for inviting me as a speaker here on this panel. In my talk, I'm going to talk about how we can estimate the prevalence of female genital mutilation in the European Union. So how can we measure the magnitude of the problem? Like this? Okay. So I was saying that I was going to try to enlighten some aspects of estimating prevalence of FGM in the European Union. It is quite a complex issue to measure prevalence of female genital mutilation in communities that practice FGM in Europe, so I hope I will be able to highlight some of those issues in my talk. And in my talk, I would like to address three questions. The first question I would like to address is, do we need to know the prevalence of female genital mutilation in Europe? The second question I would like to address is, do we currently know how many girls and women are affected by FGM in Europe? And finally, my final question I would like to address is, what has been done and could be done to increase the knowledge on prevalence of female genital mutilation in Europe? So these are basically the three questions I will try to answer during my talk. So the first question, do we need to know actually the prevalence of female genital mutilation? I think there are quite some arguments why we could answer that question positively, and I'm going to highlight some of those arguments. The first one is that due to a growing number of migrants coming from communities in Africa or in Indonesia, Asia, that practice FGM and that come to Europe, female genital mutilation has become an issue, a reality in the European Union. Those women and girls who are affected by FGM or who are at risk of FGM are facing a whole range of services within the European countries. For example, health services in the first place, but also schools, social services. They also come to the attention of the police and the judicial sector. So basically, it would be good to, if we have an idea how big the problem is of female genital mutilation, or how big the number is of those women and girls at risk and those who have been affected by FGM. A second argument, I think, in favor of, or to answer the question positively, is that in order to really assess how effective the services are that have been put in place with regard to female genital mutilation, in order to draw conclusions on the necessity and the efficiency and the efficacy of actions that have been put in place, or even future actions, I think we really need to know how big the problem is. And it will be very difficult to say something conclusive on the necessity and the efficiency and the efficacy if we don't have any data in Europe with regard to the prevalence of FGM. Now, I will talk a little bit more later on in my talk, but basically what we need of data is data that are comparable between the European countries in order to produce a total for the whole of Europe. So we need comparable data between European countries, and we also need reliable data, so data that are representative for a country as a whole. Very complicated exercise, and I will talk a little bit about those issues later on. It's also very difficult to say if the prevalence of FGM in Europe is going up or down if we don't have any data collection at intervals in time. So it is very difficult to assess trends, to say if it's increasing or decreasing in the absence of prevalence data that are reliable and that are comparable between countries. Prevalence data will also be very useful, I think, to make the problem of female genital mutilation visible in the EU. Which, making visible, I mean that FGM is put on the agenda at European level. So in order to have, or to keep FGM on the political agenda in Europe, I think it is really, it's a necessity that we have a good estimation of the prevalence of FGM. As I said before, it's also important to have prevalence data in order to track progress on prevention activities, to inform policymakers, to inform decision makers, where to put actually, or to prioritize actions in a certain country, or also at a European level, and to determine resource allocation. Amnesty International, they've said that the lack of prevalence data was one of the major missing links to the development of adequate policy response in the EU, policy response to FGM, that is. Now, I would like to also caution a little bit, because data collection on prevalence of female genital mutilation is also prone to be misused by policymakers for certain political agendas. For example, it happened with when I published my PhD thesis in Belgium, and it was on female genital mutilation in Europe. It was used by an extreme right political party in Belgium to really prove that, you see, you know, FGM is a barbaric practice, and now, and to really stigmatize the African communities living in Belgium. So we really have to, if we yield prevalence data, we really have to think also about how we're going to phrase the conclusions that we draw from prevalence studies. Further on, if we are discussing the need to know the prevalence data, I think there has been a call by several institutions at European level, both by the European Commission and the European Parliament. They have called several times for the need of prevalence data to have a clear idea of the magnitude of the problem in the EU. It has also been requested by several national governments, but also by civil society organizations. But I think more recently and very important is that also the Istanbul Convention, which is the Council of Europe Convention on the Prevention of Violence Against Women, in which female genital mutilation is specifically mentioned. The Istanbul Convention also talks about the need to have data. And this Istanbul Convention is a legal binding instrument. So signatories to the convention will have the obligation to actually gather the prevalence data. I've mentioned here in my slide the article 11 that really deals with data collection and research. So it says that the parties that are signatory to the Istanbul Convention shall undertake to collect disaggregated relevant statistical data at regular intervals on cases of all forms of violence, which includes also female genital mutilation. And further on in that article, it also says that the parties, so the member states, shall endeavor to conduct population-based surveys at regular intervals to assess the prevalence of and trends in all forms of violence covered by the scope of this convention. So I think this is really a very important instrument, but I believe it will be tackled also in the panel on the laws and the legislation, I assume. So to answer my first question, do we need to know the prevalence of female genital mutilation? I think yes, we definitely need to know the prevalence of female genital mutilation. Now, to answer my second question, what do we know so far? This section will deal a little bit more with the specificities of the methodologies that we can use to actually measure the prevalence of female genital mutilation, and it will highlight a lot of issues that we have in trying to do so. Okay, so you can see here a map of Europe, the map of the African continent, and then of Asia. And in Africa, female genital mutilation, the prevalence of female genital mutilation has been well documented in a number of countries. And that is mainly due to the demographic and health surveys that exist and the multiple indicator cluster surveys that exist and that are repeated at regular intervals. So those are household surveys that are repeated over time, and it has a specific model on female genital mutilation, which allows us to really say that over time in a certain country, the prevalence of FGM has gone up or gone down. On the contrary, in Europe, we don't have those surveys. So we don't have any systematic representative survey that is repeated in each European country that can give us the same indication of the prevalence in the European countries. And in Asia, there are a number of studies emerging, for example, in Indonesia also, that really show that FGM is also an issue in Asia. Now, what do we know so far on the prevalence of FGM in the European Union? There has been a European Parliament resolution published in 2012, if I'm not mistaken, which talks about overall the number of women and girls with FGM in the EU is around 500,000, and they also talk about 180,000 girls at risk. Now, the problem with that resolution and with the figures appearing in that European Parliament resolution is that it doesn't say how these figures were, how they came up with those figures. So it is a little bit of an issue, I think, to just pose a figure, because once you have that figure, it's going to lead its own life, you know. It's going to be repeatedly circulated without really knowing how this figure has been actually composed. The UNHCR, so the High Commissioner for Refugees of the United Nations, has published in 2013 a prevalence estimate of the number of asylum applications that were addressed in European countries. And so it says that per year more than 20,000 women and girls from FGM practicing countries seek asylum in the European Union every year, of whom in 2013 around 16,000 were potentially affected by FGM at the time of arrival in the EU. The publication was called Too Much Pain, I think. So if you like, you can search for that publication, and I've added the link in my presentation at the end of my presentation. And besides that, there are also a number of countries in Europe who have tried to estimate the prevalence, the national prevalence of female genital mutilation. For example, in Belgium, we have tried it at 2 points in time, one time in 2000 and I think it was 2004, but I'm not sure. And the last one was published in 2012, that we published something. To be a bit technical, so the prevalence studies that have currently been done in the European Union, in European Union countries, for example, the study in Belgium, we have used the extrapolation of African prevalence data, which basically means that we use the prevalence data that are published by the DHS and by the MICS in Africa, and we apply it to the female population from FGM, the female population living in a European country from African practicing countries. We apply that to that population, and then we come up with the prevalence figure for Belgium. So that's basically how we are measuring it. A lot of data sources are used in those studies: population census data containing the number of female migrants from FGM risk countries resident in an EU country, and complemented with other data sources, birth registers, for example, child protection registers, and some studies also try to include the asylum seeking registers and registers of refugees. It's very complicated actually to come up then with a reliable figure. So there are a number of limitations with using that extrapolation method. One of the major complications is that those census data that we have in the European countries may lack aggregation by African country of origin. Some countries use like Black Africans or Sub-Saharan Africans or a category other, so it is really very difficult to have a clear idea how many per African country are really staying in Europe. There are no repeated estimations, as I already said before, so we cannot assess any trend. There is a use of varying definitions of girls at risk. What is a girl at risk of female genital mutilation? Do we include second generation girls, for example? Can we really say that third generation girls are out of risk of female genital mutilation, or are they still at risk? And how can we incorporate those girls at risk in our prevalence estimation? Also, the census data, they are not repeated every year, so it is really very difficult to reflect recent changes in migrant populations, and migrant populations tend to really change very quickly. So that is also one of the limitations of using that method. The influence of migration is a big debate, and I think Sarah was one of the first ones to produce a paper on that, if I recall well. So how do we assess the influence of living in a migration context on thinking about female genital mutilation? How do we measure that? How do we take that into account in order to come up with a reliable estimation figure? It's also a big problem, and I think very few research has been done so far on that. And then also ethnicity is not taken into account in estimating prevalence, because as we know, the prevalence of FGM in African countries is not really going with nationality, but rather with ethnicity. And so we basically, if we want to know the prevalence in European countries, we would need a very clear idea about the ethnicities of the people living here, which is not kept in any registers or not normally kept in any registers, which also complicates the production of our prevalence figure. There are a lot of issues also with assessing the girls at risk, so not the girls and the women that have been excised, but the girls that are at risk. Many countries lack actually data on prevalence estimates for the girls at risk. As I said before, are the second and the third generation girls still at risk of female genital mutilation, and how do we measure that? How do we try to grasp the risk? How do we include undocumented female population? Can we include that in a prevalence estimate? And also the influence of migration, again, on assessing the prevalence of girls at risk is also at play here. Now, okay, I'm nearly done. So there are many countries in Europe who have tried to get an idea of the magnitude of the problem by doing other surveys. So there are, for example, surveys that have been done among health professionals. If I may give you the example again of Belgium, I've done 2 so-called CAP surveys, knowledge, attitude and practices surveys among gynecologists and among midwives, just to get an idea of how many times midwives and gynecologists are confronted with female genital mutilation. There are a lot of methodological issues around that, but it was just to have an idea, just the region of Flanders that was. It was not for the total of Belgium, it was just the northern region, to get an idea how big was the problem, amongst others. Assessment of the number of asylum requests and asylums granted on the fear for FGM is also a way of keeping track of the problem of female genital mutilation. Assessment of the number of registered births in family from FGM risk countries. Assessment of the prevalence of women with FGM in asylum centers and of the number of women from countries where FGM is practiced. And I believe that is how it is done in Catalonia. It was the work of Adriana, the mapping, I think. It was also mentioned in the previous at the previous round table was the hospital records. It is a very important way of trying to keep track of female genital mutilation in a specific setting. In Belgium, we have had an evaluation of the registration of female genital mutilation in hospitals, in 10 hospitals in Flanders, for women admitted to hospitals for daycare. So not hospitalized women, but for daycare. And we actually did the measurement before, so we trained the professionals in order to keep the registrations. And we trained them before, we did an assessment before and after, and we saw that after the training of the professionals, the number of registrations went up considerably. So it is not just not put, the question is not having a register, but you also need, I think, to train the professionals in order to keep really a good track of the number of, and of the types also of female genital mutilation, which is not an easy task, I would say. Other administrative records with potential that are actually underused are the asylum cases on the ground of FGM, administrative records on child protections cases related to FGM, police records, police investigations, and the number of prosecutions that come from the police records. But those are all, I would say, administrative records that are not really very well used in order to get an idea of the prevalence. So, in conclusion, the issues with these assessments and records is, again, it is not done on a systematic basis. There is a lack of aggregations of existing records. The records are all dispersed over several databases which are not linked to each other. For example, the police is a separate database, the health records are a separate database, so things are not centralized also. And training for professionals on coding and assessing FGM and codes for hospital medical records are frequently lacking. So do we know how many girls and women are affected in Europe? I would say no, we don't know yet. We don't have any total for Europe so far. Only in some countries in Europe we do have an idea of the national prevalence, but there are a lot of methodological issues that really compromise the data that we have. Okay, and so we don't know. And then my final question, which is a very short, we will have a very short answer. What is done to fill the knowledge gap so far on FGM prevalence in the EU? And I think we need to mention here the work that is done by the European Institute for Gender Equality. They have done a study on how to measure the prevalence of girls at risk of female genital mutilation. It was published in 2015, and they used a mixed method research. So they used both a quantitative method and a qualitative method, and they said they were going to implement the same methodology in another 6 European countries in the course of 2017. And then I've been involved in a project together with INET, and I think Armel Andro is here, yeah. A project with INET and Bicocca University, where we tried to develop a methodology to measure the prevalence of female genital mutilation. We've designed the methodology, we have piloted it in 2 countries, but we have met a lot of challenges in implementing that methodology, and we are going to present the lessons learned and some recommendations to have a better methodology for FGM prevalence at the end of this month at a seminar in Brussels. So that's basically what I wanted to share with you on the knowledge that we have gathered in the past years on prevalence. If you want to read more, I've added all the sources that I've used for my presentation and a number of links here. Thank you.
Y ahora pasamos, damos la
I give the floor to Elise Johansen.
This one, so you just go there. That's it. Okay. And you can move it like this.
Yeah, I just started. Yes. Yeah. Okay. This will be like a marathon with many presentations after each other. My title and the content has changed a little bit from what I said to you for various reasons, but I hope it still will be interesting. So I basically wanted to highlight some special things about the policies and the prevalence in Norway that differed or as different from Spain or from the presentations that Elise had. So and as I present some findings when it comes to trends, I present some findings from a study that I have just concluded. So in Norway, we have estimated the prevalence we are a small country with 5 million people. So even though the number of women you have estimated to have undergone FGM is low, it's only Sweden who have more women affected by FGM compared to the population than Norway. So we have a pretty high prevalence with 0.7%. What is also special in Norway is that 50% of the women who have come, or women and girls who have come with FGM, have come with the most severe type of type 3, because most of them come from Somalia, and we also have some from Sudan and Eritrea, as well as from other countries. And another estimate is made by somebody else of children 10 to 18 who had FGM prior to migration is 2008. And I think that's a very important number because most policies tend to focus on healthcare for adult women with FGM and preventive measures for children to prevent them from having FGM. But some children come with this having had before they come to the country, and they might be in need of healthcare. And that I think is a big challenge actually because there are really no policies of what is good health care or what care do they need. We also tried to estimate girls' potential. I just want to mention that when we estimated the risk, we did one more step than what is possible in many countries. We know the age when people, we know exactly who comes from which country, and we have included only children or girls with two parents from a country with practicing FGM. But we have I looked at the prevalence in the country of origin, but also the age at what they come. So if the common age, for example, for FGM in Somalia is 4 to 9 years, only girls from 10 years above are estimated to have undergone FGM at the same rate as the country of origin on the youngest generation. So we'll take it into the age of arrival as well. When we come to estimating risk, we have what we call potentially at risk, and that is all the children born to two parents from a country where FGM is prevalent, and that means irrespective of ethnicity. And that is because when you as a healthcare provider meet these people, you will not necessarily know what ethnic group or what region they come from or what family they come from. So you need to reach out to provide information on FGM. We estimated that the maximum girls at risk is 7,000. So that is that if the girls were exposed to FGM at the same rate as is their country of origin, 7,000 of the girls who live in Norway now would have been exposed to FGM. But then again, as we know that attitude and practice change when you move into exile, we said maybe around 3,000. And I honestly don't remember how we came to this 3,000 number, but we think these are maybe more really at risk, but still we need to reach all the 15,000. When it comes to the number of girls who have been exposed to FGM after moving to Norway, we have very weak data. We know about a handful, and this includes some girls who were sent home for FGM, and then since they were followed by the law, they never came back to Norway, so they don't live in Norway. They were resettled back in the country of origin, which is also one of the risks of the legal follow-up. And of course, how many have been averted from preventing, we don't know. There is a lot of cases which there is a report that there is a fear that the girl is a risk of FGM, and interventions are done, but we don't really know how real the risk was, and we don't even know whether it was averted this time or next year. So there is a lot of unknown. Then I just wanted to go very short through the history of the policy in Norway. We first had a law in 1995 against FGM. And at the time, the focus on the law was to tell medical doctors, you cannot perform FGM. There was no effort done to translate it into the languages or to disseminate the knowledge about the law to the practicing communities. It was just Norwegian doctors being asked to perform FGM and not knowing what to answer. So it was to sort of guide them. And when I started working on this topic in 1997, and I called the Ministry of Health and asked what is done on FGM, and they said, no, we have solved the problem, we have a law. So we have realized since then that it's not that easy. Then in 2000, we had a documentary where a woman with a secret camera went in to ask imams and different religious leaders and other people, advice, pretending as if she was wondering whether she should undergo FGM or not. And this led to an uproar, and immediately the government made a plan of action and made guidelines for the health care providers. And we had the first plan of action for 3 years with the project developing brochures and information material. Again, the government thought, okay, now we have solved this problem, we have the material, we have the knowledge, and nothing happened for the next 4 years, except for the established special clinics to help women with FGM, and they also strengthened the law with a duty to avert, so that if you have a suspicion that FGM is planned, you have a duty to try to avert this. And the main point of that was that also religious leaders should have that duty. There are more things later that I don't need to focus on. But the good thing is that since 2008, they also have special funding for research. They have also special funding to support NGO work. And there is funding for mainstreaming of services. We had a new strengthening of the law in 2014 when they distinguished between the severity of FGM and also the increasing the period of punishment. It also changed the regulation of what sort of interference or what sort of research the police can do, that they can listen secretly on phones and they can do more different types of investigation. And also since 2012, FGM has been sort of headed under the headline of domestic violence and together with forced marriage and strict control of youth. And since 2017, all the research are subsumed under violence in close relations. So one of the things I thought is interesting, which relating to the law, which I hear you'll discuss more tomorrow, is the way the laws are interpreted differently in different countries. So as I said, we have a duty to avert. So if you suspect that somebody's planning FGM, you have a duty to avert, either by talking to the family or by reporting to the social services. But if FGM is performed, you do not have a duty to report. And especially for healthcare providers, it is said that the code of silence is weighing heavier than a duty to avert. And that has to do with this, what you called it, neglect of, no, not neglect of care. It's to do with the child protection, because if FGM has already happened, it has already happened. So whether you go in and do something is too late. So that's why they don't have this reporting. I think it's not really said, it's under there. But there is also the healthcare providers do not want to report because they fear that then people will not come and seek healthcare for complications. And they fear that we undermine, their rapport with the communities. And in the recent study we went through some police cases where we both reports of fear of FGM planned and fear FGM has happened, is that there is a real serious dilemma by this law, is that the only ones who can now report FGM has happened are like school teachers, child nurses, no, not nurses, not healthcare providers. And the only one who can actually see whether FGM has happened is a doctor. But the only ones who can report are the school teachers and other people. So there has been a lot of reports of girls having undergone FGM where there is a total misunderstanding because they don't have the knowledge. So girls from countries with no FGM, girls with other health problems have been reported suspicion of FGM. And also, if you report for fear that a girl will undergo FGM, social service can go in and take custody over the child to protect the child from FGM. So in a way, the parents are punished for something that they haven't done, and the children. But if FGM has happened, there will be no consequences for anybody. So in a way, those who haven't done anything are punished harder than those who have actually done something, which I think is a serious dilemma, which needs more investigation, I think, in how the laws are interpreted and everything. So we have a very big systematic organization in the country. We have these plans of action. They are going with funding. So there's a systematic routines on how FGM is going to be implemented. And for implementation to be done, of course, people have to have the knowledge on how to do this. So we did a questionnaire to all the schools of education, but only for healthcare provider, to find out to what extent FGM is a part of the curriculum. And it was for most of school nurses and midwives who have a very big task in FGM. But for medical doctor, it was only for half of the schools. So you had a medical university where they had taught FGM for 20 years, and another one that hadn't even thought about this being an issue. So there's a big variety in the knowledge that healthcare providers have when they deal with people. But anyway, we have a system that when we have refugees that are collected from refugee camps, they are giving information about FGM from the time they are in the refugee camp, from the time they are in the asylum seeker. We have compulsory introductory classes, which are 2 years of schooling, learning Norwegian and society, where FGM is a topic. And you have 3 times during school year that the child will be sent a letter or given information that you can come and talk to the school nurse about FGM, when they are young with the parents and when they're older alone. These are pretty systematically carried out, but the time given can vary from 3 minutes to an hour. So it's not very in-depth, and it's only one-to-one simple presentation of the law and maybe about health risks. And to an increasing extent, they have added information about health care. But pregnancy and childbirth, it's suggested that they should ask about it, but we are not sure how much is followed through. What we also found is that there is very little coding, as mentioned here, and it's only since 2016 that ICD, International Classification of Diseases, added a code on FGM, and they're probably going to add more elaborate in the next ICD systems, ICD-11. So that will give a chance for more systematic coding and and then for more register research and other type of research. Yeah, and the other two I mentioned about the clinics and NGO. I think the challenges for healthcare, which I've been focusing on, is that again, there is no guidelines for healthcare in children. So for example, you have children who have infibulation and they have complications, and the doctors are not sure whether should they do the surgery now or should they wait until they enter puberty, should they wait until they have more severe problem, what is a too severe problem, and the sense from the qualitative study is that they tend to wait. They do not want to do surgery on young girls. One thing is because parents can be against it, and if you do such surgery, they need support from the family in the healing period. And also if the parents resist it, and there is also this fear of re-traumatization or other issues. So there is also a weak identification of some symptoms. So when it comes to menstrual problems and sexual problems, both the women themselves and the doctors are aware that they can be related to FGM. But when it comes to urinary problem and cysts, it seems to be very undiagnosed. So girls and women themselves, I have to do this. We have an ongoing study among children and youth, and many people have problems with cysts and urinary problems that they don't seek help for, that they don't know is related to FGM, and they don't even know that it's abnormal. So for example, in one interview, a doctor told me about a girl who came for examination, and she said she had no urinary problem. But then he asked, okay, how often do you have to go to the bathroom? He said, every 30 minutes. Okay, how long does it take each time? Like 10 minutes. Because she had been sent by the school because she lost a lot of classes. So they are not really aware of what is normal or what is a problem, and that something can be done about it. And another challenge is we have these 8 clinics. They were opened basically to offer opening surgeries, so-called defibrillation, for women defibrillation. But there are very few who seek this defibrillation or to make appointments, and they don't come up. So the last few minutes, I'm not sure how many I have, I will talk about a study that I done to identify what people think about defibrillation. Okay, I'll be very quick. Oh, I have water here. So I have 2 papers that focus on different aspects of resistance or attitude to defibrillation. And the first one relates to how people relate to doing defibrillation before you marry. Because the whole purpose of the defibrillation is to show upon the wedding night that you are a virgin. So if you want to have an opening surgery before you marry, it sort of removes that evidence that is traditionally practiced. And the second article is about how people relate to defibrillation later, already when you have been married, either as a part of marriage or part of childbirth. And looking at the cultural factors that somehow reduced women's uptake of these surgeries. So very quickly, these red dots are the clinics approximately placing, and the color of the map is where most people with FGM live. So we see that most of these clinics are close to where most women live. But still, some, of course, have to travel. So we estimated that around 9,100 girls, this was in 2013, have infibulation. And in that year, it was 123 people who sought help. And I'm not sure if all of them went through defibrillation again, because records are not really looked into. So my thought is that since everybody who has infibulation, sooner or later they need to be opened, because you need to open to have sex, and you need to open to give birth. And if you do this opening surgically instead of traditionally, where the man is supposed to use his penis in most communities, or the circumcised are doing it, it's much less painful, it's much less risky if you do it in a hospital setting. So if all people, which all research shows, if everybody is against infibulation in diaspora, why don't they go and seek opening surgery, defibrillation sooner rather than later? Why should they wait? And then if they are skeptical to defibrillation, does it mean that they really have changed all their attitude towards FGM? So the study was then to explore Somali and Sudanese men's and women's, how they understood this surgical operation. I don't need to go into the method. So the finding was basically that almost, I think, all informants said they are negative to infibulation. They do not want this practice to continue. But when it comes to what they call sunnah, which is supposed to be a less extensive form of procedure, they were divided. Some thought it's okay, some thought it's good, and some were against it. And also when you talked about it in theoretical terms, everybody thought that having this defibrillation done in the hospital surgically would be an advantage, again, to reduce pain and risks. But in practice, there were very few who actually sought it, and most had gone through defibrillation in the traditional way by the man opening the woman. And then the reasons they gave for this was related to the socio-cultural motivation that underlies FGM in the first place. So there were like three aspects of this surgery that was important. First was the timing, so that if you do defibrillation prior to marriage, it threatens this, as I mentioned, the ideals of virginity and virtue. And it was believed that not only that you cannot prove your virginity if you have been opened, but also that it will destroy your virginity, because once you have been opened, because traditionally opening is a part of the marriage, so that once you're open, you start a sexual life. So most people thought that if you open a woman, she will get these sexual urges and she won't be able to control herself anymore. Also then, the way the surgical defibrillation is done, it threatens virility and manhood. And that was basically for the Sudanese, this was not common among the Somali, is that the man is supposed to open his woman with his penis, and that is a show of his manhood and his strength and virility. So if she goes to hospital to have this done, he will not have this chance to prove his manhood. And the third, which was both the Somali and Sudanese shared, is that when you defibrillate in Norway, generally they open all the way at least to have the urethra visible, and some even open up to uncover the clitoris. But this threatens the ideal that male sexual pleasure is dependent on a tight vaginal introitus. So it's a big concern that if you open this, the woman will be too wide and sex will not be nice for the man, then the relationship will die and the man will divorce or find another woman. What was also very interesting is that there was no systematic variation in who thought what, depending on their age, their gender, or the time have lived in Norway. The people I interviewed had stayed in Norway from 3 months to, I think, 30 years, the longest one. Because I had a group of very newly arrived refugees who came just from a refugee camp, and some had lived in Norway for a very long time. And my informants were in general higher educated and more employed than the average Somali and Sudanese citizen. So we'll see how much I managed to show of the rest. One thing is also very interesting is that people tend to downplay the pain and the complication of penile defibrillation, and they also downplayed the extent of their cutting. So many people said they have sunnah, but when they explained what actually happened to them, it was clear that they had been closed. So this, I think I've said it. I will jump to some of the quotes. So the challenge was that people were virginity was still considered a very important cultural value. And when I tried to ask sort of, how do you show virginity if you don't have infibulation? Because I said they were against infibulation, but they were for virginity. And how do you prove it? And all the examples they gave of how to prove virginity sounded like they're still talking about infibulation. So for example, this one, the man, I asked the same question, that how could you know if a woman is a virgin if she has never been infibulated? And you see his answer, where there is blood. When they are stitched, there will be blood. And me and other boys, we wouldn't feel the hymen, but that she's open because she has been used before. So it was very strong, it was 100% conviction that a man will know whether a woman is a virgin or not, based on the tightness of the vaginal introitus. And also the women shared this view. So there's one woman who said that when a man has sex with a virgin, he will always notice. It is painful and it sort of pops when the hymen breaks. It did so with me. It could, of course, be due to my circumcision, but I think it was the hymen as well. And she said, I'll ask my husband, and he says that a man will always notice. With the virgin, it's tight, and the man has to force himself in. Actually, these are the only two who talked about the hymen, so I am not sure how common the idea of a hymen is, because sort of the infibulated scar is like a culturally construed hymen. So I think that the hymen is like a new knowledge, that there is something there that can be prove virginity. This is, sorry, boring, but I think it's also interesting, this thing about, because there is a big discussion about the sunnah changing from infibulation to sunnah. And at least from my informants, I have, I'll try working on it. Very often sunnah is supposed to be less than infibulation, but in practice it seems to be used for almost anything. So for example, one of the Sudanese women I interviewed, she said first that I had a sunnah circumcision, so my first sexual experience was easy. And when I asked what you mean by sunnah, how do you define, because every individual defined it differently. And she explained sunnah is just removing the tip of the clitoris. But then when I asked about how was your marriage, how was your first sexual intercourse, then she said I had 2 small openings, so intercourse was painful. Thank you. It took about a month before we managed. We tried bit by bit, and we bought something at the pharmacy, a sort of painkiller gel, but I felt it only make it worse. And that is, many Somali also told me that is in their home country, they have certain oils that they use to make penetration easier, and it's like a painkiller. But again, she said, I never considered to have the opening at the hospital because it wasn't so bad. So women tend to downplay their own pain and suffering and compare it with sort of other stories that I heard, which were much worse. Also, this issue about reinfibulation. Reinfibulation is common among the Sudanese. And what was interesting in this study is that several of the Sudanese women who had given birth in Norway had experienced pressure towards reinfibulation. And this pressure was also, one of the Sudanese women didn't have any FGM at all, but even she had been pressurized to go back to Sudan and have, I mean, they call it reinfibulation, but it would be infibulation because she never had it in the first place. And also what was interesting is that some of the men many of the men I interviewed were like political activists, you know, very strong, these Sudanese men, they had come as political refugees, they had been very active for women's rights in their own country. And they were very strongly against FGM, and still they felt that reinfibulation is necessary. Because a woman who had FGM or has been infibulated, she will be less elastic, so she won't go back to normal, and then sex will not be pleasurable for the man. So it was very strong, but this does not seem there is contradictory evidence, so there's not really evidence from Somalia. But none of the Somalis talked about reinfibulation or pressure to that. But they did talk about tightness being important. So this is the last quote, yeah. Somali woman who talked about tightness, and she mentions reinfibulation, although it does not seem to be practiced, I don't know. When she said, all men want tight women. We are so scared that if we are not tight enough, the man will find another new woman to marry or take a younger lover. So they do some reinfibulation in Somalia also. And my impression is basically that after giving birth, there are open wounds, and it will heal together while you have these 40 days of rest. So there will be some natural closure, but not going back to hospital to stitch. And she said it's important that the vagina is not a gaping hole. It has to be tight for the man. And she said, I feel myself when we have sex, and I'm very wet, I feel nothing. And my husband says sometimes, as a compliment, you were tight today. Yeah, and I've realized this discussion is not only related to, I know this is a broader international discourse about tightness, and it's used in different ways, but yeah. So what, okay, one last, the thing I think is that when we talk about change of attitude, I think it's very important to sort of dissect what is change of attitude. Because my study and several others has found that there's nuances in what attitudes means. So in general, when you talk about the health risk, everybody is against FGM. When you talk about religion, there is more ambivalence, particularly with this regard to Sunnah and other reasons. But when it comes to the sexual morality, those ideals are still stay strong for many. There is, of course, a lot of change, but for many, this sexual morality still, and it's expected, those who are different, those who oppose these ideals, feel that they are pressurized by the community to follow this sexual morality, so that those who did defibrillation kept it secret, for example. Yeah. And to know that this is not only to do with intellect and knowledge, it's also very emotional and relational factors that affect people's attitude and practice. Thank you.
Si quiere que me... Sí que merece un aplauso porque...
Yes, indeed, a huge applause because, well, she did an effort, didn't she? So, Sarah has the floor. There's a PowerPoint, perfectly.
I'm delighted to be here. I'm going to say something about a novel approach in how we practice the law and may use the law to protect girls. Because for a long period of time, there have been concerns about that we have so few prosecutions in Europe, what that is about, because it's often seen as if more prosecutions would be a preventive tool. So I'm going to say something about the criminal court cases in Europe and also about a novel approach we found. So the study, we collected data on criminal court cases in Europe, and also we mapped transnational movement for the purpose of having FGM performed in another country. And that was for technically the European Commission. You can find the report on the web. We had data, we monitored data collection with 11 country experts: Austria, Denmark, Finland, France, Germany, Italy, the Netherlands, Spain, Sweden, Switzerland, and the UK. And we tried to find, these countries were selected also because we knew that there had been court cases. So we haven't missed any country in Europe that has had court cases, but not all of these have had it. We have fewer than 50 court cases all in Europe. A majority, some 30 cases, took place in France in the 1980s and 1990s. So when we looked at the more recent court cases, we focused more on the recent 20. Among countries which have had court cases: Denmark, Sweden, Italy, Spain, and Switzerland. And what we found when we compared the court cases in the different countries, we found that the general rule is that if a case should be taken to court, we need an offender with a criminal intent to have FGM performed. That's the general rule. And that is what makes it hard, because you have to have both a victim and a perpetrator with connection to the European state. You can't take someone in Somalia to court in Sweden. So both offender and perpetrator need to be from the country, and you need to prove the criminal intent to make it possible to let that person go to trial. But what we found was a couple of countries, among them Switzerland, who left that position and instead they have taken cases to court based on neglect of care. They didn't have to prove criminal intent. So the basic rule is that only persons who have acted in ways that lead to a girl's being cut, and when it can be corroborated that the alleged perpetrators had this intention, only then can they be charged in court. But now we have seen a few cases where people have been prosecuted for not having protected the girls well enough from being subjected to FGM. So, could we use this, that's my question, as a preventive tool? If more European countries try to see the opportunity in thinking about legislation in new ways. Probably we would see more prosecutions if we could start prosecuting caregivers for not protecting girls well enough. You said about Norway that you have a handful of cases where we know that Norwegian girls have been circumcised, and it's the same in Sweden. I know there are fewer than 10, but a handful of cases where we know that Swedish girls have been circumcised, but with perpetrators in an African country. So probably we would get more cases, but there are also risks in this position, because there is a general principle of criminal law that prohibits carrying out extensive interpretations in criminal proceedings. So we have to be really careful with how we interpret the law. In other cases described in our material from European court cases, parents were acquitted on the grounds that they had left their girls in temporary care among trusted relatives in the home countries. And honestly, it seems they did not expect this to happen at all. So the key question here is it reasonable to sentence people for acts they have not planned, envisaged, nor desired? Is it reasonable to take them to jail? And that will be a real risk. We could see ourselves putting people in prison who are actually opposed to FGM. On the other hand, the neglect of care approach could be a powerful tool in preventive work as a deterrent. It has potential to be an important step in efforts to safeguard young girls in Europe, because it sends a clear message to immigrant groups that if you go back to your family, to your country of origin, with your girls, you have to protect them. And also it could be a useful tool for those families going back for some time, if they need to instill in their social networks that if you do anything to our girls, we risk prison when we go back. Okay, now I don't know how well you have followed. Everyone sees the conflict between the approach, criminal intent on FGM, and the possibility that we focus more on the neglect of care approach to take cases to court. So what I argue is that if we focused more on taking caregivers or custodians to court for not having protected their girls well enough, we risk an increased stigmatization of already vulnerable immigrant groups in Europe, and also increased legal vulnerability for individuals in these groups, and that will be a lot more repressive than preventive. Too fast? So, on the other hand, if used with subtlety and discretion, we might have a hitherto untapped preventive tool to safeguard girls in Europe who have not yet been subjected to FGC. And as I said before, it can also be used as a tool for families who go back to Africa for some times and tell their relatives that our girls must remain intact or I risk prison. That's a forceful tool with risks, pros and cons. That was my presentation. Thank you. Oh, yeah.
So I'll give the floor to Professor Hazel Barret.
Okay, well, good afternoon, everybody. You'll be pleased to know I'm the last person on this panel to speak, so it'll soon be lunchtime and you can visit the toilet and have your lunch. What I want to do is to talk to you today about a Daphne-funded project called Replace. This is a project that was funded by the European Union and has had two sets of funding. So over 6 years, we've had two sets of funding. So we've been running since 2010, and our funding finished in 2016. So we've been running for about 6 years with a little break in between while we did the analysis of the first phase and then before we started the second phase. So it's been running for about 6-7 years. It's a project which is trans-country. And just to put the context before I move on to the detail, we worked with African diaspora communities in 5 EU countries: the Netherlands, the UK, Portugal, Spain, and Italy. So we did work in Spain. So some of the questions that you asked earlier, I might be able to help because we did work in Banyoles. So that might be something. The communities that we worked with in those countries through our partners were Ethiopian, Eritrean, Guinea-Bissawan, Sudanese, Somalian, Senegalese, and Gambian. We were particularly funded to focus on African diaspora, hence that's the focus of this paper. As we've heard this morning, the ending of FGM in the European Union and elsewhere has proven very difficult. I think it was 1979 when the WHO called for the elimination, the global elimination of FGM, and yet the numbers increase year on year as we find more and more groups of people performing FGM, such as UNICEF suddenly discovering Indonesia last year, which many of us could have told them about well before that. We know it's a cultural tradition that is very resistant to change. And despite the awareness raising over 30 or 40 years here in the European Union about the health implications of FGM and the criminalisation of FGM in the European Union, as we've been hearing about, FGM continues to be performed on girls and women who are resident in the EU. So as a team, we thought, well, why is this happening? Because although there are many people in these communities who don't know much about FGM and perhaps don't understand the legal implications of performing FGM in Europe, many of them do. Many of them are quite well educated, as we've heard, but they still continue. They might be second or third generation, they continue to do it. And so we started to think, well, why is it that the health belief model isn't working? What is happening is it's been counterproductive in that we find that medicalisation is becoming more and more commonplace as a result of that message. And the human rights approach, i.e. the criminalisation and putting in law, is not having the desired effect. I'm not saying it's irrelevant, it's just, well, in the UK, for example, we've had a law against FGM for 30 years, since 1985, and we have had no successful prosecutions. So that perhaps gives you some context. Excuse me, let me just... So we did some work around this, and we thought, well, why is this the case? What are we missing here in terms of trying to prevent FGM being performed on women and girls in the European Union? And so we had two sort of underpinning assumptions that we started from. The first is that FGM is a social norm. It's not something that an individual chooses to do necessarily. It's a social norm. And though they might think they've had choice and agency, they probably, in effect, if you start to do the research, haven't. So in Europe, we find it quite difficult to think of health issues as being a social norm. And certainly in the UK and the countries that we've researched in, a health professional will look at an individual and try and persuade an individual not to do something or to change their behaviour without understanding that the community is also very, very important. And I think this quote from UNICEF in 2010 sort of summarises that for those of you who don't quite understand what I'm talking about, because I couldn't put it better. Even when parents recognise that FGM can cause serious harm, the practice persists because they fear moral judgments and social sanctions should they decide to break with society's expectations. Parents often believe that continuing FGM is a lesser harm than dealing with these negative repercussions. So it's a social norm. Our project comes from this assumption that FGM is a social norm, and we have to tackle it as a social norm. We also looked at why some of the research as to why FGM is practiced in the EU, and it's not simple, as we've heard already, and I'm sure you'll hear later on in this conference. This is the WHO FGM mental map produced in 1999. There are other more recent versions based on more recent research, but this one's quite visual. And basically, FGM, if you have an FGM message, for example, in the UK, and you put out a health message about FGM and say, FGM is harmful, it will affect your sex life, it will affect your health during pregnancy, you know, et cetera, if you have only had SUNA or type 1, that health message is not relevant. So basically what we have been doing in Europe is treating everybody with FGM as the same. And what we were saying is different communities are different. They have different reasons for performing FGM and different belief systems underpinning that, and different mechanisms to enforce that social norm. And we also found in our study in Bristol in the UK, a mixed community of Sudanese and Somali, that the Sudanese were re-infibulating for male sexual pleasure. But the Somali in the same street, living in the house next door, would not be doing that. So that's interesting. So these living in the same neighbourhood are doing different practices for different reasons, for different beliefs. So the replace approach is a new way of tackling FGM, working with communities. So coming back to some of the questions we had earlier this morning about involving communities. This is working with communities. We don't believe that a top-down approach is working. It's important to have that infrastructure, but we have to get communities to work together and to understand why FGM needs to be tackled and stopped. And what we've done is we've said that raising awareness is not good enough. It's important. I might use myself as an example here, not of FGM, but of being obese. Okay, I am aware that I'm overweight and I shouldn't be eating, you know, wonderful things. I have the awareness, I can tell you the calorific input of everything, but it doesn't stop me eating it. Okay, so basically what we were saying is we need to involve communities. Communities need to be part of this prevention of FGM. We need to take them on board. They need to come on board. But we also need to do more than just raising awareness and giving out leaflets. We need to change people's behaviour. And that's what we're failing to do. So our methodology is based on the fact that FGM-affected communities are different. They have different belief systems, and they have different enforcement mechanisms of those beliefs. And if we can understand those, we can begin to target our interventions to those communities, which means that the intervention is relevant, and that those communities can understand where it's coming from and where it's going to, and they can start to take ownership. And we can start to see small steps towards behavioural change. So our project focuses on communities, but we recognize that communities are made up of individuals, and some individuals are more powerful or influential than other individuals. So basically, we've looked at communities, and we've identified within those communities what we call influential individuals. Now, that might be the imam or religious leader. It might be a political leader, or it could just be somebody in my peer group that I look up to and I go to for help and advice, somebody I admire and respect. And in many of these groups, it's grandmothers. And how often do we actually target grandparents in anti-FGM programs? Hardly ever. What about men? We know men have been totally neglected in this as well. Men are important parts of these communities. Why are people doing FGM? Well, we've had the answers here from some of those wonderful quotes that we saw. It's patriarchy, et cetera, et cetera. I mean, that's a bit controversial, but men are important in this equation. If men say no to FGM, women don't do it. We know that. So, what did we come up with after our 5 or 6 years? This is an approach that is based on application. We have developed this with communities across Europe. We have trialed it with those communities, and we have evaluated it with those communities. And in fact, Elise was our external evaluator for the European Union, so she knows this was thoroughly evaluated. So, and is now being rolled out in other EU projects, such as the Change Plus project, for example. They've used our methodology. So I'll just quickly go through this because I haven't got very much time. You can read up about it. And ideally, we have a cyclic model here with 5 elements. But what we're saying is that you can't change behavior in one cycle. It might be that you need various cycles of this in order to make change. So little steps are great, but chances are we're going to make little steps rather than one big leap to change. Hopefully we will make a big leap, but it's unlikely. So the first element here is to understand the community that you're working with. Engage with the community, understand their belief systems. Why are they performing FGM? What is motivating them? What if they don't do it? What will happen to them? Will they be stigmatized, not be able to marry into the community, et cetera, et cetera? The second element then is once you've engaged with that community, as I said, understand the social norm. And lots of people will say to you, oh, it's religion, it's required. I'm a Muslim or I'm a Christian, it's required. But actually, when you get underneath that, it isn't usually religion at all. That's just an excuse. Once you start getting underneath that, you'll find, we found, that it's much more culturally based, as is probably obvious to all of you sitting here. Then the next stage is then to assess how ready is that community towards ending FGM. Now that is where we, I think, have made a contribution, because we could find nothing. There's lots and lots of theories and models that one can use to see how individuals change their attitudes and practice. We can do those, and we have done those. But how do we assess how a community is moving? So, for example, half of this room, you might be sitting there, you're all FGM, from an FGM community. Half of you are sitting here and you're thinking, I really don't want to have my daughter cut. I don't want to do these things. But you don't know that other people in that half of the room are thinking the same, because it's not something you talk about. You assume that you have to do it because this half of the room say you should do it. Are you with me? So we need to understand where we are. Is it just one person in that community? Is it more than one? Is it more than half? Is it most people, but people don't understand, don't talk to each other and realize that other people are also anti-FGM? In other words, how strong is that social norm within that community? So individuals can have a change of attitude, but we know that they don't always change their behavior. And we have come across that. And we've come across women who have actually lied about their status, etc. To women who've said they have had their daughters cut and they haven't, so that they're accepted into the community, and vice versa. So there's all sorts of issues coming on about the social norm. So how do we measure where that community is? Because where that community is in terms of its readiness to change will determine what type of intervention you will put in. So once you have done that, and I'm going to spend a bit more time talking about how you might do that, because I think it's really important. Once you've done that, you can then inform or develop an intervention that is relevant to that group of people in terms of its belief systems, in terms of its social norm, and where it is on that journey towards ending FGM. And then obviously you deliver the intervention, you evaluate the intervention, and then you start round the cycle again. So it's a cyclic framework. The bit that I want to focus on is what we call the Community Readiness to End FGM Index that we have produced. This is not our own invention. We have borrowed a Community Readiness Index developed in the States in 2006 by Plested at Colorado University, where it was applied to domestic abuse. We've adapted it and applied it to FGM. And what this index does is it assesses where communities are on 6 dimensions of change. The 6 dimensions are on the left-hand side in green. I haven't got time to go through them all, but you will see that they are very much based on knowledge, attitude, and practice, so they're based on CAP. And then these are assessed, and I'll say a little bit more in a minute. These 6 dimensions of change are assessed and scored, and then these translate into a stage of readiness to end FGM. 1 being the community is not in the least bit interested in ending FGM, it's in denial that there's a problem, etc., through to stage 9, where the community has basically said, we're not going to have FGM anymore, this is not a social norm. Okay, so we've got 9 stages of change. It's a bit complicated, I'm sorry. Hopefully the translator can follow me. So, I'm happy to talk. I'm not rushing up to get an aeroplane, so I'm quite happy to talk to anybody about this afterwards. So we have 6 dimensions of change, which when scored can be translated into a stage of change. Okay? So this is the scoring. So it actually is easier to do than it looks. So you've got this. There are 6 dimensions of change. You score your community. This is where I probably need to stand up because and then you won't be able to hear me. But basically, a community at stage 1 with no awareness of FGM scores lowly on all the 6 dimensions. And then a community which has decided to abandon FGM scores high on the 6 dimensions of change. Are you with me? And obviously, if you go through, I'll put this down, destroying everything. If you assess those 6 dimensions, you can see which dimensions need to be focused on in terms of your intervention. Are you with me? So it's a little bit more nuanced. You can say, oh, well, this community is aware, but they don't know what to do about it. Or there's nobody, an influential person in that community who's willing to take up some leadership role in the so it's, that's basically, one would score each of those dimensions. It's a bit more complicated than this. You come up with a stage of development at the bottom there. The stage of development, so those are the 9 stages of development that you come up with. You can then see, you might be able to read them better here, you can see where they might put a community in terms of its tipping point, in terms of changing its social norm. So this is all about how is this community moving towards transforming its social norm that's supporting FGM. Does that, okay? So, gosh. So these at the top here are the 9.
Tenemos un micro aquí que podrían algunas, sí, un micro para que pueda también, porque es que es un poco complicado estirar. Muchas gracias.
Yeah, I can't talk without standing and walking. I apologize, I'm not used to sitting down and talking. I tend to have to get up and walk around and point at things. So if we look at the top here, those are the 9 stages of change, okay? 1 through to 9. What we did is we said, well, obviously, that's quite granular. But if we put them together into groups of 3, we can start to see what is needed in an intervention to try and tackle FGM. So if a community was scored in as in stages 1 to 3, it usually meant that they needed more knowledge about FGM. They needed more awareness raising. Okay, so they're in very early stages. If a community is in stages 4 to 5, then they need to be given some support to try and introduce relevant interventions that are going to start to promote positive behavioural change activities. And then if a community, and we didn't come across any in this, I have to say, 7 through to 9, then the challenge there is to maintain that community, that behavioural change and support that community to maintain that social norm of not performing FGM. Okay, does that, right? So, to put them all together, this is just to put them all together, because you've got basically 6 dimensions, you've got the scoring here, the stages, the type of intervention that you would focus on. We did this with the communities that we worked with in those countries that I listed at the beginning. We did all of this, it worked really well. We also did individual evaluations of people's change, their attitudes. But we found that the community readiness to end FGM lagged behind, actually, a lot of what individuals wanted. They were held back by what they perceived was the social norm, what they perceived was expected of them. Not necessarily what was expected, but what they thought. It's all up, it's perception rather than actuality. And we then worked with those communities, and this is very much a community-based piece of work. We used community-based action participation methods here, and we worked with communities, and we trained peer group champions and others in the community. They undertook the assessment for us, and they scored their communities using that. Now, you can score them using either focus groups or individual interviews. There's a handbook if anybody's interested, but you just basically get a set of people who just represent the community. What do they think the community is saying about FGM? That's what you want. They want the social norm. What do they think? Not they think that the community thinks, if you see what I mean. And our communities here, we had no community that had gone beyond stage 4. In fact, we've just done it again in the Netherlands, and they have now gone up to stage 5. But that's a couple of years on now. So from this, we worked with those communities, bearing in mind that we know the scores for the 6 dimensions, and we know which ones they're strong at and which ones they're weaker at. We then worked with the community to develop an intervention that was appropriate to that community. And we did individual evaluations before the intervention. We did the Community Readiness Index before, and then we did it afterwards. And in all cases, there had been a shift towards ending FGM. Sometimes little shift, but nevertheless, it was moving in the right direction. The sorts of interventions that we put in, if they were in stages 1 to 2, this is the Italian, Eritrean and Ethiopian migrants. These were very transient group of migrants. They'd basically come off boats. They didn't really want to be in Italy, no offense to anybody who's from Italy. They experienced lots and lots of other problems, such as racism, how to get a job, where to live, basically how to get asylum and all of those issues. FGM wasn't high on their agenda, and many of them didn't really know much about FGM and the laws in the EU. So there, and also, because it was transient, because it was a transient community, there really was quite difficult to find a community, because people were basically just there and wanted to leave. So what we did there is we tried to put in an intervention that got people together as a community to talk about what it's like being in Europe, their rights in terms of access to asylum and housing and employment and all of those things, and then dropped in FGM as well. If you just said this was going to be about FGM, nobody would have turned up. Okay, it was like coffee mornings. It was getting people together to socialise, meet each other, and that seemed to work. We did something similar in Banyoles, where we had, but they'd already got community there, so we moved on a stage and strengthened that. What we found is that they weren't particularly aware of the legal situation here in Spain, so we had to strengthen that aspect of the intervention. They were very well of the health stuff. That when we get down to London, this was done in London, they were aware of the legal situation, but were not so concerned about the health situation, because they were saying the messages are all about type 3. We don't do type 3, or we don't, or we do some type 3, but we're now doing lesser types. We're doing sunnah, little sunnah. These messages are not relevant to us. We don't see any health problems, so why should we stop doing it? It's like my husband saying, I'm not going to give up smoking because my dad he smoked 10 million a day and he lived till he was 90. It's the same sort of idea, isn't it? So whatever. So in here, we put on specific sessions about the health implications, and in particular for men. Men don't always understand the health implications of FGM on their wives and their daughters. They for whatever reason. It's women's business, therefore we don't want to know. But when they are involved, they are quite shocked, I think, to see what, there's a young man here, which is, again, I agreed with the comment earlier, it's a shame there aren't more men here, because men need the message, whether they're African or not. We need men to go out there and give the message. So basically, these were the interventions. The interesting one, which I'm going to just finish, I'm nearly finished, is the one that we did in the Netherlands with the Somali community. This is with FSAN, for those of you who know. These were the organisation we were working with. The Somali community in the Netherlands were very knowledgeable about the health impacts of FGM and the legal situation. But they were struggling with the argument with the religious arguments. They could see the health and the legal, but for them, Mohammed's law was of higher status than Dutch law, if you see what I mean. And they were sort of saying, well, we don't want to do this, but we're not confident in arguing the religious case against FGM. So we said to them, well, how can we do this then? What would be a way to do this in your community? And we found a door in by, they said, well, Quranic school teachers. I think nearly every community has these, Quranic school teachers. Like in Christianity, we have Sunday schools, religious education. Children go once a week, usually on a Friday or Saturday, and they get told about Islam and how to be a good Muslim, etc., etc. And they said, well, that would be a really good way in. The imams were very resistant. We couldn't get into the mosques that way. But Quranic school teachers, and we had men and women here. The men did drop out, I have to say, towards the end, but the women persevered. They bridge the imam and the families and the children. And very often, parents will be sitting around while the children are receiving Islamic tuition. And children will go home, as we all know, and then repeat what they've learned. So it's a really good way of getting, across the generations and the divide, if you like. And this was a Quranic school class, which we have a curriculum. And we had a Turkish, it's Dutch-Turkish Islamic scholar at the University of Rotterdam who was prepared to be filmed. And we made a DVD, because what these school teachers said is, I don't feel I can stand up in front of a class and say, FGM is not in the Quran, it's not required by Islam. Who am I? I'm just a lowly woman. But this scholar has put it on a DVD, so they can now put this DVD on. And he quotes the Quran, the hadiths, etc., and explains all of this. So it's really helped them. We've seen quite good progress with that. We haven't come across any other project which has been able to tackle that issue, and we're hoping we can roll it out, further. But it worked well in the Netherlands, and it might be that the circumstances are different there, but that's worked very well. And as I've said, it seems that they have now moved on a stage, and if you can capture children, hopefully, it'll move through the generations. Excuse me. So my final slide really is that the community readiness assessment for us is at the heart of change. If we can understand where a community is, understand the social norm, put in place influential people, and an intervention which is relevant, sensitive, culturally sensitive, relevant, you're not wasting your money by just handing out leaflets that people put in the bin. You're actually doing something. Sorry, I'm not. But lots of things are never evaluated, and therefore you're going with a program. Oh, I've trained 100 people. So what? What's changed? You've trained them? Okay, so this we've shown can actually work, and we believe that one has to work with communities. So it's one of the very few tools that's available to evaluate changes in community behaviour and norm transformation. We know it's effective because we've used it, evaluated it, and it is now being taken up by other projects. It's been taken up by local government. In the UK, for example, my local authority is using this tool, as are others. It can help the development of appropriate interventions so that they're culturally sensitive, but also you're not wasting resources in a time when money is tight. Why, you can actually target your resource to the group you want. Yeah. And you can then use the Community Readiness Index to assess your project to see if it actually has made a difference. If it hasn't, why not change it? If it has, great. Thank you. I've got plenty of references there if people want to follow it up.
Ronda. Mariselina.
Thank you very much for this community intervention project. My short question is, how did you deal with language barrier? Because I understand of this immigrant, the language barrier.
¿Otra pregunta? ¿No más preguntas?
¿Cuál es el papel de la sociedad civil y de las organizaciones de mujeres en toda esa estructura de la Unión Europea? Y quisiera hacer un homenaje por aquello de la memoria histórica. Por ejemplo, estoy recordando, yo estaba allí también en 1999, 2000, 2001, cuando Emma Bonino empezó a organizar en el Parlamento Europeo, nos convocaba para trabajar estos temas, ¿no? Y Beijing y tal. Quiero decir que el trabajo de las organizaciones de mujeres y de la sociedad civil.
¿Y una tercera pregunta? ¿Una cuarta? Mira, ahí al fondo y aquí en la primera fila. Y ya cerramos este turno.
Yo me gustaría preguntar a Elisa si ella nos ha comentado de la intervención, desinfibulación, operación a las mujeres somalí de Sudán, si es gratis a la intervención, la reconstrucción de vaginas, si es gratis en este país. Porque sabemos que las mujeres a veces no acuden a médico, no llegan por dificultad que tienen esas mujeres. Entonces, quería saber si es gratis la intervención.
¿En qué país preguntas?
La primera que ha dicho.
¿En Bélgica? ¿En Suecia?
Sí, Elisa, sí. ¿Eh? Marocco, no, Marocco. Sí,
Noruega.
Noruega, sí. Si la intervención es gratis.
Answer immediately? Yeah.
No, we will take the fourth one.
Okay, fourth one, okay.
Mawahed?
Yes, my question I think is directed to Elise. About how would you know the prevalence in your country, for example, or in European countries? I think some measures may contradict with human rights, but is it applicable, for example, to examine any immigrant who's coming for the first time into your country to document the number of cases, and then is it applicable again to examine those who went to spend holidays in their own original countries and coming back? Is that possible, financially possible? Is that, will that contradict with human rights? I don't know. Thank you.
Pues ya os dejo la palabra. Elise, you want to start? Okay.
I would like to address the question by this lady concerning the inclusion of the civil society organizations at European level. My first ever project research I did on FGM in Europe was in '97. And it was a one-year project that we did, kind of mapping what was the legal situation and the situation with regard to health services and the socio-cultural aspects. And following that first-year project, we did the second one to establish a European network for the prevention of FGM. And that network was really a combination of a lot of community-based organizations fighting FGM in Europe, combined also with some academics. The European Network for the Prevention of FGM existed, I can't remember, 5-6 years or something. Then it kind of disappeared, but now we have the End FGM campaign, which is really a very strong network of civil society organizations, mainly, who are really very strong in lobbying the European institutions with regard to female genital mutilation and putting it on the agenda. So I think there is really a strong civil society representation, in my view, with regard to FGM that is lobbying the European institutions. So they're based in Brussels. Okay. And then to address your question, you know, if you try to estimate the prevalence of FGM, what we have tried to do is using data sources that are already there and do secondary analysis on this. So doing a direct estimation, so for example surveying women, we have tried that, we have developed a methodology, and it was very, very complicated to actually do it, to really find interviews who could go out there and try to find the women and try to interview the women. So in terms of direct estimations, I think we really face some difficulties in Europe to try to do it. I think if you really want to have a clear idea of the prevalence, the thing is that you cannot do any physical examinations of women to really assess the type they have and then record it. It's ethically, it is really very complicated and it's not done. So that's why we take recourse to the secondary analysis of data sources and try to come up with some idea of the magnitude of the problem. I don't know if that addresses your... Sorry? No, exactly, there are problems, yeah, sure. Yeah. But
can I just have a short
Creo que es importante que Sara, que quiere también aportar sobre esto.
comment on that? Because I think you raise a very important issue here, and about the Swedish situation, there is legal support to have girls compulsorily genitally examined, and they do. We have many cases, and the problem is they do not lead to trials. They find nothing. But we have a human rights issue involved in this kind of... It wouldn't be to estimate prevalence, but it's a way of discussing how far are we willing to go to detect cases. So very important. Thank you.
I would endorse what Sarah is saying about that. You know, you could, in Belgium also, it has been proposed to.
Micro?
Yeah, I'm using the micro. It has also been proposed that you need, or in the Netherlands, for example, they also proposed that compulsory genital examination should be done of all girls from communities that are practicing FGM. It was proposed by a Dutch politician at the time from Somali origin. But then they put a commission on it and they said it was against the constitution because you cannot single out one certain population and impose a measure on that. You see, and so sometimes it always comes back. You know, we have to do these examinations in order to implement the law. I'm not in favor of that. I mean, it is a very, very harsh and repressive measure. And what I'm wondering is also why is this measure suggested to detect cases of FGM, and is it not suggested to detect cases of sexual abuse in both girls and in boys? So I think if ever we were considering such a measure, I think it should be done for both boys and girls at a national level then. You see?
Elise?
Yeah. I will answer about the cost of repair. The cost was not mentioned by anybody of... we had two studies. We had one study that I did, which is about adults, about defibrillation. And there is also a pilot which preparing for one about youth and children. I have interviewed, I think, 16. It's a colleague of mine. And price was not mentioned by anybody. It's part of the public healthcare system, so it costs about 35, 40 euros. And also we have that if you have medical costs more than 250 in a year, everything above that is free. So the cost is not, but it could be a problem for youth because youth, of course, have less money. And if they also don't live in one of those towns where these hospitals are, so they would have money for traveling and also time. So if they want to keep it secretly, and they cannot ask for money and time off to go to have the surgery, then it can prevent.
Okay, first question was about language barriers for the replace methodology. The replace methodology is based on communities working with them, within the communities. So therefore there wasn't a language barrier because it was people from within the community undertaking the assessments. However, we did have to get it translated so that we could understand and to do the evaluation. So the whole point of this is it's communities being empowered to do this for themselves. That's not to say there aren't translation difficulties within communities, but they do seem to be able to overcome that. In terms of defibrillation, in the UK, it's free of charge because it comes under the National Health Service, but reconstruction doesn't. So you can be defibrillated for medical reasons that we've discussed, but if you want to be reconstructed, you'd have to pay for that.
Define what reconstruction?
Well, if, for example, you could be defibrillated, opened up, but if you want your clitoris reconstructed, you can't have that done free in the UK. But it is available. I think in Spain, actually, you can, but I might be wrong with that one. Somebody else would know more than that. And in terms of inspecting children, in the UK, we've had all of these debates. But since October 2015, we've had a new law in which allows the authorities to put what we call FGM protection orders on girls who are suspected of being at risk. And they have to be really suspected of being at risk, and they are inspected. So they stay at home with the family, but they are inspected by a medical practitioner to ensure that the parents haven't had them cut. Or if they take them out of the country, they're inspected before they go and when they come back. But it's on really high-risk groups.
Pues vamos a dar terminada esta mesa. Por la simple razón, yo creo que Adriana quería añadir algo, pero como el Congreso sigue, y vamos a tener muchas mesas, y sobre todo es que me acaban de decir que el taxi está abajo. Y como no hay un lugar muy fácil para aparcar, pues vamos a dejar que Elise y Elise vayan corriendo a coger su taxi. Agradecerles a las 4 pues, su ponencia y compartir su sabiduría, sus experiencias. Y como me estaba diciendo Adriana, no hay varita mágica, ¿no? Vamos a seguir aprendiendo a lo largo de estas jornadas y siguiendo también identificando dilemas de todo tipo, incluyendo los éticos. Gracias.